Peds Gastrointestinal Disorder number 2. Esophageal artesia and trichoesophageal fistula. The esophagus terminates before it reaches the stomach, ending in a blind pouch, or a fistula is present that forms an unnatural connection with the trachea. The condition causes oral intake to enter the lungs or a large amount of air to enter the stomach, presenting a risk of coughing and choking. Severe abdominal distension can occur. Aspiration pneumonia and severe respiratory distress may develop, and death is likely to occur without surgical intervention. Treatment includes maintenance of a patent airway, prevention of aspiration, pneumonia, gastric or blind pouch decompression, supportive therapy, and surgical repair. Assessment are frothy saliva in the mouth and nose and excessive drooling. The three letter C's. C for coughing, C for choking during feeding, and C for cyanosis, unexplained cyanosis. Regurgitation and vomiting, abdominal distension, increased respiratory distress during and after feeding. Preoperative interventions. The infant may be placed in a radiant warmer in which humidified oxygen is administered, and mechanical ventilation may be necessary if respiratory distress occurs. Maintain NPO status. Maintain IV fluids as prescribed. Monitor respiratory status closely. Suction accumulated secretion from the mouth and pharynx. Maintain in a supine, upright position at least 30 degrees upright to facilitate drainage and prevent aspiration of gastric secretions. Keep the blind pouch empty of secretions by intermittent or continuous suction as prescribed. Monitor its patency closely because clogging from mucus can easily occur. If a gastrostomy tube is inserted, it may be left open so that air entering the stomach through the fistula can escape, minimizing the risk of regurgitation of gastric content in the trachea. Broad spectrum antibiotics may be prescribed because of the high risk of aspiration pneumonia. Post-operative interventions. Monitor vital signs and respiratory status. Maintain IV fluids, antibiotics, and parenteral nutrition as prescribed. Monitor strict intake and output. Monitor daily weight. Assess for dehydration and possible fluid overload. Assess for signs of pain. Maintain chest tube if present. Inspect the surgical site for signs and symptoms of infection. Monitor for anastomotic leaks as evidenced by purulent drainage from the chest tube, increased temperature, and increased white blood cell count. If a gastrostomy tube is present, it is usually attached to the gravity drainage until the infant can tolerate feedings and the anastomosis is healed. Then feeding are prescribed. Before oral feeding and removal of the chest tube, prepare for an esophagogram as prescribed to check the integrity of the esophageal anastomosis. Before feeding, elevate the gastrostomy tube and secure it above the level of the stomach to allow gastric secretions to pass to the duodenum and swallowed air to escape through the open gastrostomy tube. Remember, before feeding, elevate the gastrostomy tube and secure it above the level of the stomach to allow gastric secretion to pass to the duodenum and swallowed air to escape through the open gastrostomy tube. Administer oral feeding with sterile water, followed by frequent small feedings of formulas as prescribed. Assess the cervical esophagostomy site if present for redness, breakdown, or exudate. Remove accumulated drainage frequently and apply preventive ointment, burial dressing, or a collection device as prescribed. Provide non-nutritive sucking. Provide non-nutritive sucking using a pacifier for infants who remain NPO for extended periods. If a pacifier should not be used if the infant is unable to handle secretions. Provide non-nutritive sucking using a pacifier for infants who remain NPO for extended periods. But a pacifier should not be used if the infant is unable to handle secretions. Instruct the parents in the technique of suctioning, gastrostomy, tube care and feedings, and skin care as appropriate. Instruct the parents to identify behaviors that indicate the need of suctioning, signs of respiratory distress, signs of constricted esophagus, poor feeding, dysphagia, drooling, coughing during feedings, regurgitated undigested food. Gastroesophageal reflux disease. Gastroesophageal reflux disease is backflow of gastric content into the esophagus as a result of relaxation or incompetence of the lower esophagus or cardiac sphincter. Most infants with gastroesophageal reflux have a mild problem that improves in about 1 year and requires medical therapy only. Gastroesophageal reflux disease occurs when gastric content reflux into the esophagus or oropharynx and produce symptoms. Assessment for gastroesophageal reflux disease: passive regurgitation or emesis, passive regurgitation or emesis, poor weight gain, irritability, hematemesis, heartburn in older children, anemia from blood loss. Intervention for gastroesophageal reflux disease: assess amount and characteristic of emesis, assess the relationship of vomiting to the times of feeding and infant activities, monitor breath sounds before and after feedings, assess for signs of aspiration such as drooling, coughing, or dyspnea after feeding. Place suction equipment at the bedside. Monitor intake and output. Monitor for signs and symptoms of dehydration. Maintain IV fluid as prescribed. Complications of gastroesophageal reflux disease includes esophagitis, esophageal strictures, aspiration of gastric contents, and aspiration pneumonia. Remember, complications of gastroesophageal reflux disease include esophagitis, esophageal strictures, aspiration of gastric contents, and aspiration pneumonia. Position the infant. The infant positioning. The infant is placed in the supine position during sleep to reduce the incidence of sudden infant death syndrome, unless the risk of death from aspiration or other serious complications of gastroesophageal reflux disease greatly outweigh the risks associated with the prone position. Otherwise, the prone position is acceptable only while the infant is awake and can be monitored. In children older than 1 year, position with the head of the bed elevated. Diet for gastroesophageal reflux disease. Provide small, frequent feedings with pre-digested formula to decrease the amount of regurgitation. Nutrition via nasogastric tube feedings may be prescribed if severe regurgitation and poor growth are present. For infants, formula may be thickened by adding rice cereal to the formula. Breastfeeding may continue and the mother may provide more frequent feeding times or express milk for thickening with rice cereal. Burp the infant frequently when feeding and handle the infant minimally after feedings. Monitor for coughing after feeding and other signs of aspiration. For toddlers, feed solid first, followed by liquids. Instruct the parents to avoid feeding the child fatty foods, chocolate, tomato products, carbonated liquids, fruit juices, citrus products, and spicy foods. Remember, instruct the parents to avoid feeding the child fatty foods, chocolate, tomato products, carbonated liquids, fruit juices, citrus products, and spicy food. Instruct the parent that the child should avoid vigorously play after feeding. Instruct the parents that the child should avoid vigorous play after feeding and avoid feeding just before bedtime. Medication: antacid for symptom relief, proton pump inhibitors, and histamine H2 receptor antagonists to decrease gastric acid secretion. Hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis. Hypertrophy of the circular muscles of the pylorus causes narrowing of the pyloric canal between the stomach and the duodenum. The stenosis usually develops in the first few weeks of life, causing projectile vomiting, dehydration, metabolic alkalosis, and failure to thrive. Assessment for hypertrophic pyloric stenosis: vomiting that progresses from mild regurgitation to forceful and projected vomiting. It usually occurs after a feeding. Vomitus contains gastric contents such as milk or formula, may contain mucus, may be blood tinged, and does not usually contain bile. The child exhibits hunger and irritability. Peristaltic waves are visible from left to right across the epigastrium during or immediately after feeding. In hypotrophic pyloric stenosis, peristaltic waves are visible from left to right across the epigastrium during or immediately after a feeding. An olive-shaped mass is in the epigastrium just right of the umbilicus. An olive-shaped mass is in the epigastrium just right of the umbilicus. Sign. Right there. Look at the picture. Right there. See? There's an olive mass. Sign of dehydration and malnutrition. Sign of electrolyte imbalances. Metabolic alkalosis. Intervention: